Thank you, everyone, for being here today. I know your time is valuable, and we hope to make sure that you have the best possible information out there for you. We'll wait for one more minute so that we stick to the time. Thank you. You know, I'm so glad I have the step stool. Yeah. Yeah, I thought I only needed it in the OR. Now I seem to need it everywhere. Seriously, like my parents, what were they thinking being short? Yeah? All right. I am actually going to take a chance and we're going to start the lecture introducing our esteemed panel. And if anybody has any questions, we will reserve it to the end of the talks. There will be 5 people giving really nice talks. I don't know about the last one, which is me. It's kind of sus, but everybody else, yeah, really good. So you're in for a treat, though we say so ourselves. I have first up a face which is familiar to probably everyone in this room, Dr. Paul Yost. Dr. Yost, beneath his calm demeanor, actually hides a vista of extreme accomplishment. He's a Stanford undergrad, medical school from Baylor, Texas. So he's right down the street in Houston. He did 2 residencies, peds from Miami and anesthesiology at UCLA. We won't say how long ago, but yeah. And then he's currently he's chief of staff at Children's Hospital of Orange County. But besides all these, he has also been doing medical legal consulting for 25 years. And it initially just started with a niche pediatric anesthesia case, which was, hey, I can handle this. And then he has developed his vista to include a wide variety of cases. So now we can listen to what exactly he did to develop this whole alternate, fulfilling career. He has also spent 10 years in city government and also as mayor. So he has a wide variety of experiences that we can draw on. I welcome to the podium Dr. Paul Yost.
Well, thank you for that very kind introduction. I greatly appreciate that. And I want to thank you all for coming too and to supporting our meeting here in San Antonio. I don't have any disclosures at all other than that I do get paid for what I do for medical legal consulting. And what I'm going to talk about today is kind of how to do it and why you should do it. And I really think we need more anesthesiologists who are rational, reasonable people in doing it. I did it initially because I thought it was kind of interesting. And I think it makes all of us better doctors. I think there's a lot of risk management involved. We see how people get into trouble and see how lawsuits develop and see what the requirements are for proving a case and how to deal with that. And so I think that really does help. It is relatively low risk. I haven't been sued as being a consultant yet, and I hope that doesn't happen. But we really do need good anesthesiologists involved. And how to do it? Well, for me, it started with kind of a real niche pediatric case. I was a pediatric anesthesiologist. I had a colleague in my group who was doing a ton of this type of work. And he had a case, and he didn't really want to do it because it was more specialized than what he did. And so I ended up looking at it and going through it and stuff. And I found it really, really interesting. And first of all, I'll say a couple things, too. In terms of doing these cases, most of the time, it's unlikely that you even get deposed on a lot of the work that you do. And it's even less likely that you end up going to trial. I think I've been to trial twice in 25 years. The first case was one of those times. And it was pretty funny because the plaintiff's attorney is one of these really theatrical guys, and he would scowl at you and look at you and try to shake you up and stuff. And they'd turn to the jury, and he'd smile, very benevolently. And it was so funny because it was a total baloney case. And the jury found for the defendant in about 20 minutes. And then what was even stranger was he came up to me about a month later, and he wanted me to do a case for him. The plaintiff's attorney did, because he liked me. And that's kind of how these things sort of get going, is if you do a case and you don't bill inordinate numbers of hours, you're a rational person, you're a reasonable person, you present yourself well, your name kind of gets around. There are some companies that do, I think there's one called Seek or something like that. I have never done that. And when you get into this work, when you do get deposed, one of the questions you always get asked is, do you advertise your services? And if you do, they're going to look at every advertisement that you've ever done. And what you're really doing is, and they'll ask you this too, is you're not really paid for your opinion, you're paid to be an expert to review a case. And I guess one of the other questions is well, I'll go through some more how to do it too. And what I do when I get a case is I'll talk to the person, I'll see if I'm an appropriate expert for them. You really want to pick cases in the field that you practice. You know, you don't want to, like, for a while I wasn't doing much OB, and I shied away from almost every OB case. But I would take like peds cases, peds cardiac, adult cardiac, because that was kind of the stuff that I was doing. But you really do want to be a subject matter expert. And then when I get a set of files or a case, I'll put it in a file, and I'll open 2 files that I keep. You know, one is called master, and that just lists my time and how much time I spend on each case, and you know, and the hours and what I'm doing. And the other is notes. And in the notes, I try not to be really specific, because when you get deposed, they'll ask for those documents, and you don't really want to explain everything that's there. So mostly what I put down is, because some of these records are like 1,000 pages long, is, you know, on what page is the anesthesia record, on what page is the pre-op note, on what page is the post-op note, on what page are any of the pertinent findings and things like that, so that I can go back through the records. And then occasionally at the end, I'll kind of summarize sort of my feelings about kind of what happened or not. And then I set up an S-Corp, and that's more kind of whether you're going to do that as an anesthesiologist or not. But I run everything through the S-Corp. Whether that provides any protection or not, I'm not 100% sure, but I just find that that works pretty well. And then I send all the revenue through the S-Corp, and then I pay myself and give myself a W-2 that comes out the other end of it. And I said most cases settle. Many cases don't go anywhere. And I think also you want to be really honest with the attorneys. I guess the next question is, do you do plaintiff or do you do defense? And I probably do 95% defense. I do some plaintiff stuff, and I think it's kind of important to do both. And I think it's good that you're reasonable, because I've had several plaintiff cases where a plaintiff's attorney would bring me something, and I would look at it and I'd say, look, you really don't have a case. And the plaintiff's attorneys don't really want to take a case that they're not going to win on, because from a plaintiff's perspective, you know, they're putting all the money up front. They're paying all of their experts up front. They're getting all the opinions up front. And if they're not going to win, they're out all of that money unless they charge it to their client, which sometimes they do. So they kind of really want to know that. You know, like, you know, recently there was a case I got asked about, and it was like use of succinylcholine, and the plaintiff was pretty unhappy about having a lot of muscle aches and a lot of other things and some other complications. And the plaintiff's attorney, who was kind of a friend who I've known for quite a while, came to me and said, do you want to take this case? And I looked at him and said, well, you know, what you're trying to examine is this within the standard of care? And the definition of standard of care is, what would a reasonable anesthesiologist do under similar circumstances? It's not like the highest care. It's not like, you know, Mass General or, you know. Sorry about that, but you know, or you know, Harvard or one of those places. But you know, it's what would your average anesthesiologist do in that setting? I said, okay, so yeah, we now have ROC. Yeah, we now have Sugammadex. Yeah, that's probably a better way to do this. But Sux is in every anesthesia cart you're going to find, and it says on the bottle it's used for facilitating oral tracheal intubation. So are you really going to be able to prove? And then on top of that, if the defendant goes into court and says, yeah, you know, I put him to sleep and I tried to mask him and I couldn't mask him very well, so I gave Sux. Well, all of a sudden now that's medically indicated. So I think that, you know, that's not a good case that you want to bring. So they didn't sue the person. So that's an instance where I think it's helpful being a reasonable person and working on kind of on both sides of that. And your job, I said, really is to, you know, look at the case, you know, and then also to go through and to say, you know, and to tell the attorneys, they want to know what the arguments are on both sides. They don't just want to know what the defense is. They want to know what the plaintiff is going to bring to the situation, as well as what, you know, arguments you're going to make to defend that case. And there's been a lot of defense cases that I've picked up and I've looked at and I said, you know,
You need to ask them how much they want the check written for, because I can't defend this, I'm sorry. And that happens once in a while. And they want to know that also, because they don't want to spend a huge amount of money trying to defend a case, getting all the experts and going through it, and then end up losing the case. And so basically when you do that, maintain confidentiality, look at the case, try to determine if it's within the standard of care or not, go through all of those arguments, think about it from all sides, talk to the attorney about it, and then kind of go from there. And should you advertise? Some do, I don't. And I think my name is well enough known now that people come to, I have more cases than I could possibly want to do. And I think if you want to get into this, I think what you want to do is to find someone who does this kind of work and tell them you'd like to do it too. And most people who do it and are reasonable will happily send you a case your way. And then once you kind of get going, it kind of perpetuates itself. So don't take cases that you're not doing on a regular basis. Don't ever fabricate, don't ever lie, just say what you think. And if you stay within the truth, and then think also that whatever you say may end up on a screen, and it may end up in front of all your colleagues too. And they always ask you, do you know the ASA has a committee that looks at this? You're not gonna lie, are you? Because we could be sending you to the ASA. And it's like, well, yeah, of course. Of course I know that. I'm not gonna say anything in this deposition or ever that isn't supported by the facts or isn't supported by the standard of care. And then they kind of scowl and kind of go on to their next question. But they try to shake you with some of those questions. But a couple other tips too is always pause before answering a question. Make sure you understand the question. Don't just blurt out right away, and never give more information than what they're actually asking. I mean, those are all real standard things. And then, avoid absolutes. Like say, yeah, I don't do that because I never do that. And they'll say, never? Really? What about if you're in Zimbabwe and you're doing a medical mission? Would you never do a case without entitled CO2? They'll kind of push you on those things. So always avoid absolutes and say, no, the standard of care is this, and I'm doing that, and just when you're generally talking. And then when some of the depositions, like I did one recently, and the attorney was just a royal pill. And he asked me the same question. This deposition went for 3 hours. He could have gotten my opinions on the case in 20 minutes. And he asked the same question 10 different ways. And they're just trying to get you to make a mistake or to say something differently or to respond to that. So I'm over my time. I'm going to hand this back off to Lalitha, and we'll, what's that? Okay. Okay. Actually, I'm over time now, so I'll let the next person go. So next person is, and we'll save for questions for the end, because I'm happy to answer any questions you have about this. I've been doing it for like 25 years. I find it's a wonderful way to kind of supplement income and to have another revenue stream. So I'll be happy to chat with you about doing it and some of the ins and outs of how to do it and how to stay out of trouble. And we need good anesthesiologists doing this. We really do. There are some liars for hire out there that will say things that are just, and I see them sometimes when I get a case. There's some guys that, some guy in Florida that's been all over these plaintiff cases, and he says some of the most ridiculous things. But we need good, rational people to be involved in this, so don't shy away from it. And if you want to do it, let me know, and I'll try to help you do it. Anyway, I'm off.
Thank you, Dr. Yost. I learned a lot of things today. I am not sure I'm ready for medical legal consulting, but thank you very much. A very interesting and very innovative talk. I'd like to introduce somebody who probably doesn't need any introduction, Dr. Jennifer Root. She's an anesthesiologist from South Carolina who has spent 19 of her 28 years as a 1099 physician. She has worked across multiple settings, community level, ambulatory surgical centers, small operating rooms, level 1 trauma center, VA hospital, and even an office-based practice. She has supervised a care team and worked personally. So she has done it all, and she knows plenty about the upsides and the downsides of locum tenens. So we've heard so many good stories about locum tenens. Gives you independence, gives you freedom, gives you control. But what about the dark side of locum tenens? Dr. Root is here to tell you that all that glitters is not gold. If you are interested in locum tenens and you do not want to put down roots, you know who to go to, Dr. Root.
I'll use the box too. Thank you. Yeah, I've been in this space for a long time, and I've learned a lot of lessons, and I was really kind of excited to be able to come and share, because everyone always thinks of the good things, but they don't always think of the bad. All right. Well, we'll just go to the slides. So there's a couple of ways you can divide this up. You understand what the job is, talk about the professional challenges, the financial impacts it can have. There's some legal and ethical issues involved. And then at the end, which I think is really important that no one discusses, is mental health and physical health considerations. La vida locums. I need to trademark that. Everybody kind of knows what it is. I just kind of threw this up there to remind everyone what it is, but you know what it is. There's a lot of reasons, and we talk about the flexibility. You choosing when to work, where to work, how long to work, for how much money. There's lots of really cool reasons to do it. People want to do it when maybe they have children and they can't work full-time with call, so they go and do more 1099 work while they still need to have the child care responsibilities. Some look like we're doing here, talking about end of career, where you just want to slow down, maybe stop taking call, right? I mean, there's opportunity everywhere. I kid you not. You can't shake a stick and not find somewhere that wants you to come into an office-based practice, an ambulatory center. My level 1 trauma center down the road is constantly using locum tenens. So there's opportunities in all aspects of what we do. So the professional challenges, one of the biggest ones is leading the team. So you're going to show up somewhere, maybe where you've been in practice for a while. You know the skills of the people you're working with. You know their names. You get out into the locums world, and sometimes you're not quite sure of the skill set of the people you're supervising, and you're the leader of the team, so it can be very stressful. It's very important to be a good communicator and a collaborator when you're having to walk continuously into settings where you don't know people, and you've got to really work on your way to communicate as well, so that you're not deemed offensive to people. I can get away with saying some pretty off-color things to people I've worked with for a long time. But if it's somebody that I don't know, you really have to reel in your humor sometimes. You've got to be very why'd you do that? Like, you can't, you know what I mean? Like, you just have to be very more political when you're doing these sorts of things. Another big thing is you show up and you don't know the equipment, you don't know where to find things. Somebody needs you to grab a glide scope. Take a little time on your first day, especially, to figure out where stuff is. Find out where the stairwells that get you to OB the fastest. You've got to navigate this whole new environment on top of all the stresses of navigating the new team, dealing with surgeons you don't know. So try to drop the stress level as much as possible and get in there and figure out the facility. Policies are really important. So I'll bring a description. One of the guys, that I'm working with right now is a locums, and he came in, and this was 2 weeks ago, and he did not realize we had a policy at our community hospital that if your PA pressures are greater than 60, then we sent you a mile down the road to the heart hospital, because at my facility we didn't have in-house cardiology, we don't have people to do TEE, we didn't have nitric oxide, we didn't have milrinone, right? All the things. We know how to take care of these patients, but we just didn't have the resources, so we always moved them down the road where there were the resources. He didn't know that. He didn't come in and ask, okay, what are all your policies on all these things? So he never got that memo, went ahead and put a patient to sleep. The PA pressures were 94, by the way. As you can imagine, it wasn't really a great outcome. So know the policies. It's a great question when you're on first day is I'm assuming you're holding GLPs for a week, right? Do you have standards or cutoffs for aortic stenosis or other sorts of things? What are the resources in this facility? Do I have the ICU care if we're going to do big cases? What is your ICU care like here, right? These are all things that will help you be more comfortable navigating this. Professional growth. opportunities, it's more in the young crowds when I talk to them. Like if you kind of jump out of residency into this lifestyle, you will never sit on a hospital committee. You will not have mentors that guide you. There's a huge loss for the early career physician when they jump into this. And we don't realize how much we take that for granted, but it's a big thing. And if you go spend the first 5 years out of residency, you're not going to get the added skill sets that you really need to be developing during this time. Another thing that I like to talk about is, like, I'm really big into advocacy, and I've spent my entire career being a strong advocate in my state, going to the legislature, developing relationships. If you're locums, you're never going to really get that opportunity because, you know, you might only be in Montana for 6 weeks, and then, you know, then you're down in D.C. for another 2 months. And, you know, you have to keep in mind that you're going to miss out on a lot of the other sorts of professional development that's important. Personal and financial considerations. Sometimes it can be good to have the flexibility for your family, but sometimes traveling can also add stress and strain. You know, you're not there for your family, you've had a bad day at work, you get home, they're not going to be there for you. You know, my husband, at the end of each day, luckily I'm married to another anesthesiologist, so he really gets it when I complain at the end of the day, but you won't have that when you get back to the hotel room, right? Personal well-being can often take a huge hit. So these are all things to keep in mind as negatives, that you've got to have some strategies ready to go in these areas. There's often variability in financial planning because when you go from job to job, sometimes there may be a gap. Sometimes they don't have a place for you to go that you want to go. So you might sit for a month or 6 weeks without any income. So it's really important for you to have strategic budgeting. You know, as Dave Ramsey always says, you got to have your emergency funds, 3 to 6 months of expenses. These things, when you're 1099, become more important just to give you the financial stability. There are a lot of legal and ethical issues as you get on the road. First of all, if you work through a locums company, really pay attention to the details in that contract. I've seen some people get burned before. So if you don't know a lawyer, it doesn't hurt to find a contract lawyer and spend the money on the front end so you don't pay for it in the long run at the back end. Liability is a huge issue. So especially this crowd that's more the end of career, if you are only carrying $1 million policy, because that's the very bare minimum that's required in the state that you're in, and you lose a $5 million lawsuit, where's that money coming from? Like, your assets are at risk if you do not have the malpractice that can cover. And I'm going to tell you, when you're the locums guy, you're the guy that's the traveler, nobody knows you, they don't have a personal relationship with you. If something bad happens, where do all the fingers point, right? You're easy to throw under the bus because you don't have any of those relationships with your surgeons and staff. So in South Carolina, I actually, when I first started doing this, they had this really crazy state-sponsored malpractice product that had developed out of the 70s when nobody in South Carolina could even get malpractice. So the state had to come in and start this fund, basically. They offered an unlimited product. I paid for it. I mean, hey, I couldn't lose a dime. Right? They could sue me all they wanted to, but the state covered unlimited. Now, obviously, from a fiduciary standpoint, they ended up learning that they couldn't run the malpractice program that way. And through the years, they've actually brought it down. Up until last year, when I flipped back into the employment sector because of a long story. But up to that point, I was still carrying a $5 million, $7 million policy, right? People say, oh, but that makes you the big target. Could. But if you got a $1 million and you lose more than that, like, what's the sense of security? I had a lawsuit in 2016, and I had at the time a $7 million, $9 million. But I had so much comfort knowing that at least I wouldn't lose my 401k. I'm not going to lose my assets, right? Like, that sense of relief and comfort was worth every penny of that product. So if especially locums companies, they're going to try to lowball you and give you the very cheapest product they buy. Don't stand for that. You know, even if you have to go around it and add on your own, do it. It's kind of like when you go get your homeowner's umbrella, right? If somebody has the slip and fall in your yard so you don't lose your house, you got to think, you can't rely on the locums company to really care too much about you and your personal life and your finances. Sometimes, there can be quality of care concerns as you're traveling around simply because, as I mentioned, the challenges of working with the team, knowing where things are you really giving the highest quality care you might be giving had you been back at your home facility or the place you spent 20 years, right? So you want to maintain that same quality of care. And there can be ethical challenges that you're going to come across doing this. And again, you don't necessarily know all the people you're working with. And again, these are things to think about ahead of time. Figure out strategies that you want to employ to how I will handle if this situation arises or that one. And then mental health and provider health issues. I was working at one of my facilities one day, and we get this phone call, hey, do y'all got any room? Can we move cases over there? And I'm like, what's going on? Turns out that the locums that had shown up at the other facility had come in intoxicated, okay? If you were in a regular practice and you'd been in a practice with somebody for 10 years and you had somebody with a substance problem, and many of you have gone through this, you get the family of this person, you have an intervention, you load them up in the car and you drive them to rehab, right? People are very invested in you and in getting you the help you need. If you're a locums and you show up somewhere where nobody knows you, you're living out of a hotel room, I mean, they basically just told him to kick him out the door, and that was that. What's wrong? Oh. I thought you were telling me I'm past time. Not quite, I'm almost. Okay. So without the support systems, and quite frankly, there are some people that leave to go on the road because of bad home issues, right? Maybe they're going through a divorce and they haven't maybe necessarily gotten the mental health that they needed, and they're out on the road and they're very susceptible to drug and alcohol use, right? You're sitting there by yourself lonely in a hotel room, and it's a thing. So understand too the risks you're taking with getting the blues, and how are you going to handle that? If you go to a community, you might want to do a little research. Is there a community group involved? Like, I love to do X. Is there a community group that does X? Like, is there a running club? I love to run. Is there a sporting group? I love to sport. You know what I mean? Is there like a sports bar where everybody who loves football likes to go? It's important when you travel to try to make some little relationships and build a little bit of support around you, right? Being by yourself in a hotel room, it can be a recipe for disaster. The other thing, well, the one more thing I wanted to comment about was the second victim. When you're in your own facilities with partners and everybody knows and loves you and you have a bad outcome, I know in my facility we have a lot of support where people come and talk to you about it and let you vent and express how you feel and are there to support you through that process. Locums are not going to have that. In most places you go, there's not those sorts of relationships where they're going to come and be like your buddy and say it'll be all right, So how are you going to handle a bad outcome at a facility when you're surrounded by strangers? What's your coping mechanisms going to be there? And the chronic disease. So it's really important if before you go on the road to engage with your own healthcare providers and make sure that you can have a way to get your prescriptions. You might want to do a little research. One of the first few days that you're on the job, hey, who's your dentist? Who's your primary doc? Where's the best, acute care place to go? Because if you have a problem and you're sitting in a hotel room and you're having chest pain, it can be kind of a scary situation, right? What do I do? I'm not at home. I don't know anybody here. At home, I know the cardiologist. At home, I know who to call. One of the locums that I work with last December, I guess after the second week, things slow down through Christmas and New Year's, so that's a real slow time during locums work. You often don't book work. And so it was the middle of December, and it was the last time I saw the guy. He comes in second week of January, and I'm like, Frank, great to see you. How you doing? And he rips open his scrub shirt and goes, look at this. He had just had cabbage. And I was like, but I just saw you a month ago. What happened, right? He's like, well, I was having some heartburn, and he's like, I went back home since I didn't have work booked, and my cardiologist said, hey, let's just put you on the treadmill. And they like, oh, no, let's take you to the cath. And then it was like, oh, we're going to go to the open heart. The guy was 3 weeks post-op, and he shows back up at my facility. I'm like, what the heck, right? You just had, I said, What? You should have given yourself more time. Like, that's a lot of stress to put on your sternal incision. He goes, well, actually, I worked last week at a GI center. I was like, you're a nut. But anyways, health emergencies can happen on the road, especially in the older crowd. So just make sure that you're prepared for these sorts of things and think about it ahead of time and have a plan. Because trying to come up with a plan in a hotel room at 10 o'clock at night is not the time to have the first thoughts on that. All right, in conclusion, lots of opportunities. I've been doing locums a long time, thoroughly enjoyed it. I don't know that I would have had the option. You know, I would have gone into a practice, worked there for 20, 30 years. I have been in every setting possible. I have worked with hundreds of nurses and surgeons across my state, and it has been truly just a gratifying career. But there are a lot of challenges. You need to know they're there, and you need to work out the strategies beforehand. But that's it. Thank you.
Thank you, Dr. Root. That was indeed an awesome lecture, which makes me happy I have roots. No, I'm sorry. So I have the pleasure, the distinct pleasure, to welcome Dr. Scott Kelly. Dr. Scott Kelly is an amazing person who I actually have worked with at Brigham and Women's Hospital in Boston. He has done an amazing job of juggling multiple careers. He is currently the Chief Medical and Safety Officer at GE Healthcare. He is also a full-time anesthesiologist. He does a lot of overnight calls to reach that credit. He has also been the chief till recently at Emerson Health. And he is a father of 5 kids and is super involved and knows even when their baseball and softball games are. And even just listening to his CV, I get exhausted, so I don't know how he manages it. His early career was at UCSF as a medical student, anesthesia resident, and as a transplant fellow. And after 10 years leading the liver transplant team, he took his first industry position at Aspect Medical Systems in the Boston area, and hence we got him. We took him to Boston at Brigham and Women's Hospital, and he has held many senior medical roles at several medical device and pharmaceutical companies while maintaining clinical practice. And trust me, that's not an easy place to work at. And for the last 3 years, he has been the Chief Medical and Safety Officer at GE Healthcare. He will describe various potential roles for the anesthesiologist in industry with his special expertise. I welcome Dr. Scott Kelly.
Thank you, Lalitha. Thanks for the opportunity to talk a little bit about my career and where I see potential options if some of you are thinking about a transition from your current clinical practice, perhaps into different roles as we near retirement. Press harder. Okay. I do have a disclosure. I have a job, so GE Healthcare is currently paying my salary, and there is an equity component to that. I don't think it's be directly related to our presentation today. So first of all, we bring a lot to the table. It's our broad clinical experience and critical expertise in disease states, patient safety, and perioperative care. So think about the range of patients that you care for throughout your career. You are bringing a lot to the table. What does that provide us? The strong foundation in pharmacology, physiology, and technology, experience with patient monitoring, safety, and risk management, and finally, the translational insights about how we bring our clinical practice into saying, what could be the next for product innovation, whether it's pharmaceutical or devices? So it's my belief that anesthesiologists have a lot of skills and experience that are highly valued across the medical industry. But what are the potential roles where we could step in and play? And I've tried to break it down into some buckets. The first would be in clinical and scientific leadership. So a medical director position, oftentimes a clinical scientist, are often driving the design and oversight of clinical trials which are necessary to get new drugs developed or new devices approved. The medical science liaison is a special position inside pharmaceutical companies where they're really tasked for non-commercially communicating science directly to clinicians. And finally, where my career has taken me is as a safety physician in pharmacovigilance to ensure the safety and compliance of the products that are on the market, to detect problems and do the right corrective actions. There's also the whole regulatory and development side. So an R&D organization is a multi-year effort to develop these new drugs and they need clinical innovation. And I think this is where anesthesiologists, with their insights, can contribute to new therapies, new anesthesia delivery or monitoring technologies, and hopefully bring those to practice. There's a whole special segment, subspecialty I would call, of really the regulatory aspects of how do you support, document, and defend the FDA and EMA submissions. To get a drug approved or a device approved is a lot of work, and companies have to invest a lot of time and expertise in order to get that milestone. On another side is really strategy and education. And this was my first entry point, was really as a medical affairs director. How do you help guide the evidence generation strategy? What types of studies are going to help make a difference and actually drive the adoption, confidence, and utilization of a product or a therapy? A medical education director might be more focused on saying, if we have an approved product, how do we better inform and educate the medical community, in this case the anesthesia community, about the ins and outs, the pros, the cons of a new device or a new therapy? And finally, the market access director. Many of you probably don't realize this key role, but we have new drugs available. Big question is it covered, right? Oftentimes, we don't always see that coverage element within our hospital settings, but for outpatient therapies, very important. Can a drug actually be covered by insurance? If not, it's going to end up in a self-pay category. I do think some of the emerging opportunities will clearly be in the worlds of digital health and technology. It doesn't take long to walk through the exhibit hall and see where AI-enabled technologies, AI integration is really going to transform much that we know about our devices and technologies. Whether they're AI-enabled monitoring, imaging systems, wait till you see what's coming in the world of ultrasound, trying to make our job easier and faster. And I think that's a big part of where AI is going to help us, is really workflow automation to make the minuscule steps go faster and easier and more reliable for us. Same thing with anesthesia systems. And then human factors experts. Let me tell you, an engineer is typically not a physician and definitely not an anesthesiologist. They need help understanding what works for us, whether it's the mobility aspects, the user interface. These are great areas where we can provide really substantial input. But Lalitha, I enjoy this talk, saying, okay, nearing retirement, what to think about. So, for this talk, I want to say what are potential entry points around retirement. And the first bucket, kind of like Dr. Yost was saying, this world of consulting. That might be a reasonable first place to start. You all have expertise, and we're clinical experts, we're experienced providers. In the device and pharmaceutical world, trust me, you're already labeled a key opinion leader. That just means you know what you're talking about, and you can express that in one way, shape, or form. Companies like the input from key opinion leaders. It may come in the form of an advisory meeting, maybe a one-day meeting where they want to talk to you about a specific thing. You may serve on a longer-term advisory board for a specific company developing a therapy or a technology. You may even be asked to help share your key opinion and your leadership speaking on behalf of that company. But these are clearly consulting opportunities. Unfortunately, Paul, we can't pay you what you charge for legal consulting. It's highly regulated, so they can pay you what's called the fair market value, and there are companies out there that determine the fair market value for an anesthesiologist serving different roles. But it is a consulting opportunity, and you can think about that because it will work around your schedule. There might be a little travel. Dr. Root, not as many nights in the hotel, but there are some opportunities to actually have some travel and further engagements with both local, national, and even global colleagues in this type of format. There's also research opportunities, and even as we're nearing retirement, each of these may be a potential opportunity for you. Many companies have investigator-initiated sponsored research where the onus of the investigation lies on you, the investigator. So you could come up with a study, A company would pay for that study. What are they looking for? A, is it aligned with their strategic goals? They want to see applications, utilizations of their products, their therapies, their devices. They want to have it with a high degree of confidence you'll do what you're saying. That's one of the biggest challenges with these types of research. Will it get done? So don't say it's going to be a 10,000 patient study and you'll get it done in a year. Be very reasonable, and the companies may support that type of opportunity. And again, it's something different than day-to-day clinical work. You could also become a site investigator. Many of the studies funded by companies are multi-site investigations, and they're looking for site leaders. So again, you will be compensated for that, and it's really driving a research organization. There's a third category that many of us aren't aware of, but many of these studies require what's called a medical monitor, where they want someone independent to help drive the appropriate enrollment of patients or subjects. They're following the right inclusion-exclusion criteria. Events come up, adverse events. Is it related to the study? Is it related to the drug, the therapy? They need kind of an independent voice, and that's where I believe our roles as physicians and as anesthesiologists, we could slide into that. I'm currently supporting a pain management study. The independent medical monitor happens to be an oncologist. She said, I've never done a pain study, but I've certainly looked at a lot of labs. I can figure out what's going on with these patients. But again, it's another potential entry opportunity if you're thinking other than just standard clinical anesthesia work. And finally, you can take the leap. I happened to take the leap 25 years ago, a full-time position. You know, and one of the things I see as I interview other physicians for these types of roles is the clinical experience is not always a one-for-one for industry experience. So, you know, I'm looking for people that kind of know the ins and outs of the industry, the regulations and things like that. It's not always saying, well, I know you've been in the department chair for 10 years. It's a little bit different on this side of the fence. So just something to think in mind there. The other challenge that we have, honestly, yes, the exhibit hall downstairs seems big to us. In the world of medicine, it's relatively small. Anesthesia, unfortunately, is considered a small therapeutic area, so there are relatively few companies, and all in all, relatively few programs giving us the direct opportunities. But so what are some of the takeaways? I'm a strong believer, and I think I'll credit this for my own career, that it's our clinical depth and systems thinking that allows us to be valuable partners in innovation, product development, the integration of these new therapies and devices, as well as their safety across the healthcare industry. There are a variety of potential roles in industry that exist, so if you're tempted, maybe start to think about it, and maybe I gave you some examples here. There are both part-time, the consulting world, as well as full-time positions out there. You could think about the complete pivot from clinical to industry. It's hard, but it's not impossible. How I made it, I still don't know, but it was a giant leap of faith, and I had a lot of, I would say, patience and support from the first company that I joined. The anesthesia space, again, is relatively small, so the direct one-to-one link of where you might be landing may be outside of anesthesia. But think back to your broad clinical experience, all the different patients that you've cared for, all their therapeutic or all their disease states that you've helped manage. So consider those other therapeutic areas. You have to expect competition from many physicians. It doesn't take long, and you know, I tend, and it'll be here, I look on LinkedIn. Suddenly, within 2 days, 200 physicians have applied for a medical director position. So there are a lot of physicians actually looking for these types of roles. There's a great deal to learn, particularly when you take on a new role. And my first job, someone said, well, this is like your residency, and I wasn't ready to do the residency. I think a better term is a fellowship. In one of my transitions to a small pharmaceutical company, suddenly I was managing osteoarthritis products for pain products for osteoarthritis. I had to do a fellowship in osteoarthritis to really understand what's that disease state, what are the treatment options. It's not all knee arthroplasties, but so give yourself that time to learn, and we're all capable of learning. And finally, feel free to explore. Myself, I think LinkedIn actually will give you a lot of potential opportunities, but do the tab that says read more. See what they're looking for in terms of expectations, the roles, the response, and what type of background they're looking for. And it really doesn't hurt to apply. That's the only way you're going to kind of learn the ins and outs. Thank you very much for your time today.
Thank you very much, Dr. Kelly. You opened up a whole new vista of opportunities for us and gave us specific inroads into industry. That was awesome. Thank you. I now have the pleasure of welcoming our next speaker. At the ASA, unless we've been living under a rock, we probably know this next speaker really well. It is my pleasure to introduce Dr. Beverly Phillip, who is a full professor of anesthesia at Harvard, the founding director of the day surgery unit at the Brigham and Women's Hospital in Boston, and she has published and spoken internationally and widely and is well known for her expertise in ambulatory anesthesia. She has also been the author of many, many research papers, the past president in 2021 of the ASA, past president of the SAMBA, and she has also contributed in many consulting activities as well. She has served as a chair of the Joint Commission, Ambulatory Healthcare Professional and Technical Advisory Committee, and the Board of Directors and the Standards Committee of the Accreditation Association of Ambulatory Healthcare. She is a founding participant of the CMS Advisory Panel on Ambulatory Payment Classification Groups, and is a past president of the International Association for Ambulatory Surgery. She is also the editor-in-chief, past, of the International Journal of Ambulatory Surgery, and is a Nicole Lecturer to the IAAS. If you are as exhausted as I am from listening to her achievements and want the name of a good therapist, I have one. But it is indeed my extreme pleasure to welcome Dr. Beverly Phillip.
Super. Thank you for taking up so much of my speaking time. But seriously, joking aside, and what this session is about is to really sort of give you ideas and make sure you come back and talk to each of us about the details that interest you. So I've been looking for quite a while, sort of in the background, thinking, so what do I want to do when I'm not going to be an anesthesiologist most of the time? And I've just been, because we've seen people transition to retirement successfully and some less so. And so I've sort of had a antennae out there for a while, and I came across something that I ended up interesting me a lot, and I'll tell you about it. There we go. I have to tell you, I gave a talk next door, and it didn't work at all, not just for me. It wasn't my thing. So what I came across was a discussion of a group called SOAR. It's a management consulting group. And what they do is do pro bono management consulting for small nonprofits. Their mission, I'm going to tell you a little bit about the organization, and they'll tell you about how and what it's like to go into this line of work. I'm just going to stand a little. The organization has three value propositions, three customers, so to speak. One are the nonprofits in our area who have great ideas of wonderful things to do, but they don't have any leadership skills on how to make that happen. There are a lot of people who've had some sort of management experience, and as I'll be talking about, that includes pretty much everybody in this room. How you have these skills and you have more time, how to give back to the community with something you already know how to do. And it's also been very helpful for the larger philanthropic, the funders, those who fund philanthropy, because now they're sure that the money they're giving to these valuable local organizations is actually going to get used and they're going to reach their goals. the kind of groups that we consult with pretty much run the spectrum of what is out there. About half social services, half arts and culture organizations. There's some education, some healthcare, aging and youth services, and also groups who work to improve the environment. And what they're looking for, they mostly come asking for, we need a strategic plan. That might be, they also might need how to, any number of, starting with a needs assessment. What do I need to do what I need to do? And so the need is very large. To meet this group of people who started this particular organization now are recruiting consultants. And this has been going on since 2006. And what's in it for you, for me, as being a consultant for this, is that we get the opportunity to meet new people who are professionally interested in what we're interested in, use and grow your skills, and really give back. Give back in a really, really meaningful way. So how do you do this? There are listed qualifications. You have to live in the area, because a lot of this is, there is local contact. You go and meet with this organization, see how they're doing things. You need some level of significant executive or professional experience. Physicians, they think, pretty much qualify off the bat, because all of us have done something to organize work in our operating room. Whether you've been, a section area leader. This is not 4 chairs of departments, as sort of was hinted at previously. That's a skill that is only useful for running departments. But if you've any kind of getting people to work together, any kind of organization, if you ever run a budget, all of this is of use to these lovely small groups. So what I'd like to tell you about is give you a little bit about my journey, how you become a consultant. At least twice, they reach out through various channels, including LinkedIn and such, to ask for interested parties. And you get an interview with one of the more senior people, and then they hold classes where they teach you what you need to know about using the skills you have to work with these consulting groups. I did my training last fall, and we are class 32. So this is really an ongoing ongoing opportunity as it develops. We all each class gets a series of 8 lectures, and you go for about 5 hours a day, 1 day a week, and they show you how nonprofits work, and both how to look at how they need things like strategic planning, how to apply it, what you already know, to what you don't know, to the project involved. I should add at this point that they also continue to have frequent professional development workshops about interesting topics, about interpersonal interactions, all sorts of every month, every other month. So this is, you're intentionally joining a community of other people who've done professional things and want to find a way to use it. What a consulting project looks like is organizations request assistance. This group is known in the nonprofit area and is recommended by the donors, and they request assistance. There's an online computer thing, RFS is Request for Assistance form. Some very senior folks in the group, who we call coaches, they contact the organization and talk with them whether this is even feasible. I mean, if they have no organization at all, we can't build an organization from scratch. What we can do is we can improve it. So we look for some general suitability, that they at least have some feet on the ground, and what they want to do matches what we want to do. What the organization, SOAR, which is this consulting group, sends out with emails with project alerts when these come up. And they happen around the year. You get them a month, a couple of times a month, to the consultant pool, and then you get to choose. You volunteer for the projects that interest you, where the topic area of which this nonprofit does is something that you'd like to spend some time helping with. People are occasionally invited in to the group by these coaches if you have some special skills, but pretty much it's your choice, it's always your choice of whether you want to do it or not. And then they try to identify 3 people who will work together on this. You're not doing this alone. You have people who, all of them over time, have gone through one of those sets of training sessions. So you start with a common vocabulary, and then you work together to with complementary skills and to bounce ideas off of each other. So this is the project I'm just finishing up. The Project Alert Force, an organization called OARS, which is a watershed association, which is a very, many of the, they promote the well-being and advance the cleanliness and the well-being of these rivers that run all through New England. This is one for the Concord and Assabet and Sudbury, which is sort of northeastern Massachusetts. 10 board members, 7 staff, and volunteers who collect water science samples. So this one sounded interesting. I happen to know this group. I'm a kayaker in my other spare time, and I actually know these rivers well. And I think they do these groups do a really nice job, and I thought I'd like to help them do it better. So how does the project start up? It starts up that the 3 of us who want to work on this project go have a go, no-go call with a prospective client. That we introduce ourselves, and we tell them from the outset, look, this is not your paid consultant where they're gonna come in for 2 days, download a templated 3-inch binder, put your name on it, and give it to you. That isn't how we do things. What we do is we're going to spend some time. These projects are over several months. You learn about the organization, and we give them the skills. We guide them through the process of developing their strategic plan or whatever the project is. And then they tell us about themselves, what their priorities are. Do they have a mission statement? I mean, what are they actually, protecting the water is nice, but you need a more concrete idea of what you actually want to do. Frequent problems are related to tension between the volunteers, the board of directors, and the executive staff. This happens in, I don't know, pretty much every organization. But how is the tension manageable? Does the board, if the staff has come to you for help, does the board want it too? And this goes in both directions. Sometimes the answer isn't yes. And are they willing to donate the time to do this? And if it's so, you have a consulting agreement. As the projects go on, what it starts with, this is sort of what happens as you go through one of these. The first thing we did was help them develop a way to sort of decide where they wanted to go. So we took they had form a strategic plan, and we got people together and said, well, let's brainstorm, let's freewheel. If resources weren't an issue, what would you like to be? What this organization like to be in another 5 years? And we worked with them. They came up with a whole lot of ideas, and then these groups met as a whole to discuss each other's ideas, because of course there was a lot of overlap. When you had this huge bucket of what to do, then we helped them form a smaller group that took all of these inputs and massaged it into something that might be a strategic plan. And what a strategic plan formally consists of, this you learned all in the class. If you haven't seen it before, you know about this beforehand. Then, part we just finished is then the staff took this strategic plan draft and then polished it into something that they could with more detail and could use, and it is going to their board later this month for final approval. What they're going to do from there is that this is a 5-year plan, and then they're each year going to carve out what they can do in each of the areas. So where do physicians fit in this? Out of my class of 9 or 8, a third of us were physicians. Some had all sorts of leaders. One was a very small practice group leader. One was a physician who led a clinic in a gynecology well-being, something in her facility. All sorts of assorted skills, but physicians do really well at this kind of stuff. And I think anesthesiology even better than most of the other physicians. We're used to organizing, that we find ways to put things in buckets and plans to make things happen. That's what this is about. And the projects, so what we have here is a way to really use what you already know in a way that is A, tremendous fun, and B, really helpful. The projects go for, the work is, I don't know, 4 or 5 hours a week over a bunch of months. We do it on a time frame that suits us. If I have a vacation plan going to somewhere else, it'll wait for another week. This is how this is arranged. So it works around each of our schedules to make, and each of their schedules. If they go on vacation for a week, it can also wait, to make sure that the outcome that we're looking for is going to really benefit the organization. Because that's sort of the point. These consulting projects are a win-win for everybody. The organization is getting done what it wants to get done, which is protect and clean their rivers. The community that they hope to benefit is actually going to benefit from their really great idea. And we, the consultants, have a good time and are valuable. Finished. Last point is that this may sound like it's a unicorn, it's a one-off. It's not. If you go even search, how do I find volunteer opportunities near me? There is huge, a whole page comes up, and a page below the page comes up. There are easily findable ways to do this, to using online search to get intro. So that's the search I used at the top. And you will find lots of things. They are by geography, by interest, and there's tremendous opportunity to use the passions you already have. Thank you.
Where is mine? I don't see mine.
Did they not get you uploaded?
Yeah, I did upload it.
Well, while she's looking for that, did you have any questions for the people that have spoken already real quick while she's looking for her stuff? Just please come to the microphone. Do you have any quick questions too?
You must have questions.
Does anybody have any questions?
Here we go. Yes.
How do you how do you capitalize your malpractice for locums when you get started? Because it sounds like if the locums organization lowballs you and you really want to hire one, and let's use your home state of South Carolina as an example, what kind of monies are you talking about?
So first, I want to make it very clear that I have never worked for a locums company. I started out at the very beginning. I did not want a middleman that was going to turn around and short me and kind of make the home team pay through the nose. I don't think that creates great relationships. So I made a point of either contracting directly with the hospital or directly with the private practice at all times. But I have worked alongside many locums through the years who work through those companies. So I've always paid my own malpractice. It's one of my 1099 business expenses. It is an above-the-line deduction. You're right. But you've got to do some research and see what that's going to cost you. Okay. So in South Carolina last year, I paid for a part-time.
Just to finish the question.
Part-time contract was it was $25,000 for a part-time malpractice policy.
Wow.
We'll get back to.
We'll get back to it in a second. I know we're running out of time, but I just wanted to introduce you guys because we have such a pool of talent here to this one topic. Anesthesiologist in global health. What exactly can we do? My name is Dr. Lalita Sundararaman. I'm an anesthesiologist at Mass General Brigham in Boston, and I'm also the president of the Massachusetts Society of Anesthesia. I have no disclosures. I'm not so high up as Scott Kelly. So, how can you help? You can either provide direct patient care, you can help in training and education, you can help develop sustainable programs which foster local growth, you can help advocate for global health, you can provide financial support for the ASA Charitable Foundation, which itself supports all these other things in multiple countries, or You can participate in the Committee for Global Health if you don't know where to start and you just need a step up. So how about hands-on patient care? If you want to take home one slide from this entire talk, this would be the slide. So what exactly is it? Yes, I want to join Doctors Without Borders. They prefer people who speak French. That completely rules me out. Second, what about mission trips? Yeah, you can do them through the Committee of Global Health or even through your institution. Check with them first. What about the World Federation of Society of Anesthesiologists? Did you know that every ASA member is a member of the WFSA? You don't need to pay a separate membership. And they have mission trips. They even have a mentor-mentee matching program. If you don't want to get your hands dirty, but you want to help somebody else get their hands dirty, that's the way to go. Match up with a mentor and mentee through the WFSA. Get a mentee of your choice in the country of your choice, and you can help make a change. You can volunteer to teach in Rwanda and Guyana through the ASA Charitable Foundation and the Canadian Anesthesiologist Society of International Education Foundation. Sounds a mouthful, but they actually do a good job. So you can teach and train in Rwanda and Guyana. And if you don't want to do all that and you just want to do telemedicine consulting, there are opportunities for that. You can be retired to do telemedicine consulting and consulting on pain management and other features, and you need to have a license when you go on mission trips. So you need to be an active practitioner. So what about education and training? As I said, many universities already have these systems in place. We have Duke University, which does in Ghana, Uganda, Kenya. We have the University of Utah, which does excellent programs in Gambia, Honduras, and Cambodia. We have the Stanford Center for Global Health. And remember, the Stanford Center for Global Health also has global health mentor and mentee matching. Harvard also has a global health fellowship, and it has a global health fellowship for international people from low medical countries who actually come here and train with us and go back and take our expertise there. You can also get invited through talks, through contacts in the ASA to speak in India, Pakistan, Bangladesh, Cambodia, about all the stuff that you have learned over your years. So there are choices. What about India? I can give you a leg up if you want to speak in India and to use your telemedicine expertise there. There are many CME programs, guest lectures, where if you want your specific area of expertise to be driven home there, that's the place to go. There are people who are thirsting for knowledge in these countries, and they value your expertise, even if you're retired, to come there. They like your expertise in tumor board meetings, liver surgery pre-conferences, teleconsultations, pain management consultations, all these areas. They actually want our expertise. In fact, one of the areas in which we actually specialize, so why am I here? Why am I even giving this talk, right? Like, what am I qualified for? Well, a few friends of mine and my family, in honor of my father who passed away at the age of 17 for me, we started a charitable center in India. Was it an easy task? No. It was extremely difficult with all the red tapeism in India. We specialize in red tape. We learned that very well from the British. So even getting an ultrasound license would take 1 year. So we started a semi-charitable center, and for a sum, you won't even believe it, of $7, we did an ultrasound, ECG, PV, exam, and also a consultation for basic healthcare services. We were able to reach a wide swathe of patients, and we had a lot of difficulties doing that. Why? If you see here, we also first initially participated in, this is like really difficult, huh? This, I understand Dr. Beverly Phillips' problems. So we had a, how do you even do this? Does it happen? It's not working. Hey, things happen, especially in our ORs, right? So this is one of the programs we started for awareness. You know, like India has an emerging drug awareness program, a huge drug intoxication program. You won't even believe it. A lot of the drugs are actually coming from Mexico. They can't come to the US, I suppose, so they're coming to India. We will take anybody. So, yeah, huge drug intoxication program. So anesthesiologists were involved in planning these programs and about emergency resuscitation techniques. And did you know I did the whole thing through Zoom? Zoom meetings. You can do it in your spare time, right? And then, I wish I could show you this photograph of us operating in the OR. We actually did a lot of issues. Yeah. So we did a lot of cases. You know what? I'm just going to chuck this. I don't need this because who needs it? So we had a lot of difficulties. I'll tell you the brass tacks like it happened, right? I had a lot of ideals. I wanted to go start this charitable center, help a lot of people. Expect blocks, expect obstacles. There will be people, like people down the street. There were 2 small clinics who said like, oh, that doctor's from America. I don't think she's qualified to practice in India, you know. I have an Indian degree as well. I have an Indian license as well. I had to advertise that multiple times. There were people who would spread rumors. Yes, these things happen. Whenever you try to do a good thing, there is always people blocking you. Not only universal acceptance, as you probably know. So you have to try that extra mile to go and actually bring about change. Are you ready to do that? Near retirement, when you have more time, maybe yes. When you've already piled up enough money that you can have a comfortable lifestyle and you don't need to like do the daily grind, that's probably a best option. When you want to leave behind a legacy, that you're actually doing something, you want to change people, that's a good option. But be ready to face obstacles, right? And that's what I would like to say. Is it changing at least now? Probably not. Uh-huh. Yeah. This is, see, now you have actually live proof. You see that lady in the bindi was standing with the anesthesiologist? That's me. And that was actually my sister, who's an OBGYN there. And we are doing stress incontinence laser ablation under sedation. You will see the absolutely brilliant anesthesia machine that I have in the back. Total modern technology, right? But that's what you expect. When you're starting out, that itself was very expensive for me to purchase when I started it. And hence, you develop slowly. You have the confidence in yourself, and we can do it. So remember all these options, and that's the important thing. So if I want you to take one current slide to take home, that would be, oh, what a mess. If I want to take one slide to take home, there are many opportunities. Go to the ASA Charitable Foundation. There's a list of volunteering opportunities which are available. There's a list of opportunities which you can do, which you can participate in even if you're retired. Because it's a myth saying that if you don't have an active license, you can't do anything. You can still do a lot of stuff. And if you're still near retirement and you have an active license, oh my gosh, there's so many opportunities available. Thank you for bearing with me, even with all this technological mess, and I really appreciate it. Thank you.